Good afternoon. My name is Mariana Rodriguez. I'm a first-year resident at Beth Israel Deaconess Medical Center, and today I'm be presenting this project titled Systematic Intraoperative Assessment of Robotic Technology During High Complexity Surgery. Oh, thank you. So sorry. We do need to disclose that this project was funded by SAGE's Robotic Surgery Grant of 2019. Currently, we know that new MIS technology has revolutionized common procedures. The goal is to reduce pain, expedite recovery, and early discharge for patients. This proof of concept had been evaluated by the laparoscopic cholecystectomy, who has evolved into the gold standard. Also, robotic prostatectomy has improved anatomic access and superior outcomes on the urologic field. However, the impact of MIS technology on high-complexity surgery, such as HPV, has been protected in its implementation due to its high potential morbidity, lower volume, and long learning curves. Prior analysis of these long learning curves have showed that it's limited to the surgeon technical performance and that have not been evaluated for the full OR team. Some of the fundamental challenges include situational awareness and shared mental models. And we know from prior studies that proficiency depends usually on complex interactions between all members of the OR team. Also, teamwork, technology, and standard operating procedures, and also patient factors play a crucial role. The study design for this project, prospective data evaluating the impact of robotic technology is currently missing. And we know that performance and workload from the entire OR team can be analyzed through flow disruptions. So this was the primary outcome from a study. The definition of a flow disruption was any event, action, or failure to act that prevents all members of the operating team from performing their assigned tasks and completely interrupts the progression of a surgery. Flow disruption were further classified based on their severity, and severe flow disruption included near misses and accident. A near miss was a flow disruption exceeding the physiological threshold for potential harm and was considered a fleeting learning opportunity. The hypothesis for this project was that process variability, suboptimal team dynamics, and the lack of standard operating procedures are the major root causes for most flow disruptions during high complexity surgery. This was a single institution prospective observational study. It was an international collaboration of the Division of Quality Improvement of the Beth Israel Deaconess Medical Center, the OR Executive Committee, and the Maastricht University on the Netherlands. We used pre-specified data collection tool for both identification, classification of root causes, and observers were validated team training, and an inter-rater variability was calculated among them for validity. Study data was mostly direct observation of process flow between all OR team members. There was no recording of perioperative outcomes or linked to any intraoperative observations. The procedure cohort was defined by a specific CPT codes. Complex surgery was mostly HPV surgery and colon and rectal surgery, and the reference cohort was laparoscopic cholecystectomy and robotic prostatectomy. No urgent procedures, reoperations within 90 days, or multivisceral resections were included. As a result, the inter-rater variability among observers was above 0.9. The sample size was occurs for all the cohorts, and the magnitude included 208 cases, 3,269 flow disruptions, and 880 hours of observation. The overall characteristic of the flow disruption, this unadjusted analysis shows that HPV surgery was the target organ with higher flow disruption, and that the event classification was mostly interruptions, followed by near misses, safe, and only one accident. The major root causes in this unadjusted analysis show that teamwork, followed by teaching, external factors, and technology were the main root causes for flow disruptions. On this multivariable analysis, we tried to assess the impact of duration as a surrogate marker of complexity, teaching, target organ as a surrogate marker for difficulty and surgical approach, and the same thing was done for the robotic cohort. We see here that both longer cases, complex and more difficult cases had the higher frequency of flow disruptions. And also we created a multivariable logistic regression model to assess predictor for severe flow disruption, which were the near misses. We can see here in this adjusted analysis that technology, teamwork were the major drivers for near misses, and interesting, teaching was a protective factor for severe flow disruption. The same result was observed for the robotic cohort. As a conclusion, we can see that the frequency and severity of flow disruption increase in parallel with procedure duration and complexity. MIS also showed to increase the total number of flow disruption, especially during the non-surgical phases. The robotic platform amplifies teamwork challenges among OR personnel who are already managing advanced technology. Teamwork was the major contributor of flow disruption, followed by skill acquisition or teaching and technology. However, again, teaching showed to be a protective factor for severe flow disruptions, while teamwork and technology were the main drivers for high severity flow disruptions. Thank you. Happy to take any questions.